Hey everybody, welcome. Thank you for joining at this hour, 6:30 um, on this Tuesday night. I want to introduce myself. I'm Dr. Feldstein. I'm excited to have you guys all here to go over a minimally invasive option to treat enlarged prostates. We have a lot of good informative slides, and at the end, we'll do a question and answer session. Hopefully, all your questions will be answered. So a little bit about myself. So I'm native to the Philadelphia, South Jersey region. So I actually did all my training at Drexel University. I did my bachelor's and master's in biomedical engineering at Drexel University. I actually went to med school at Drexel as well. I did my fellowship training in interventional radiology at Thomas Jefferson University in Philadelphia. I've been practicing as an attending for about a decade now. We do a whole variety of procedures, including obviously prostate artery embolization. So we're going to get into BPH and kind of what causes it and what options there are for everybody. So unfortunately, BPH affects almost all of us. So by age 80, 90% of us are going to have enlarged prostates. Benign prostatic hypertrophy, as it sounds, it's benign, so it's not cancer. It is treatable, and it's, again, very common. And a lot of reasons we get it. Some of it's genetics. Your dad, your grandfather may have it. It's also environmental. It just happens to, as we age, there's really no way around it. So BPH, as the prostate grows, so the prostate sits right below the bladder. So as it grows, it starts pushing on the bladder. As you can see, this schematic, a normal prostate sits right under the bladder. It almost looks like a walnut. As it grows, it starts to squeeze the urethra, which is where the urine goes. So if you see on a normal prostate, you see these arrows, which is where the urine is going to flow, and that channel gets very tight and almost non-existent as the prostate enlarges. This is what causes all those unfortunate, bothersome symptoms with BPH. So the common BPH symptoms, which a lot of you are aware of already, urgency. So you have to go to the bathroom. You have to find a bathroom wherever you are as soon as you can. Difficulty initiating a stream. So actually starting that stream is difficult, or when the stream is started, it's very weak, very slow, and it's interrupted. And urinating a lot. So the biggest complaint I get is urinating at night. Some of my patients are going to the bathroom 4 or 5 times a night, which means you're not able to sleep, which is obviously very frustrating. Inability to empty the bladder and all of the above. So some patients have 1 or 2 of these symptoms. Some of us have all of these symptoms. So the complications of an enlarged prostate. So urine can leak. You may have to wear pads or diapers, forming incontinence, which again is not at all something we want to live through, especially if we're out traveling, doing our day-to-day activities. It can lead to urinary tract infections. Patients can become very sick as urine becomes infected. It can lead to bladder stones and bladder calculi. It can damage the bladder to a level where the bladder is not even working any longer. And some patients will require a catheter. Either they'll put a catheter in themselves to evacuate the urine, or they'll have an indwelling catheter. And worst case scenario, it can actually lead to kidney failure. One important point to make is that enlargement of the prostate, this is benign and it does not increase your risk of cancer. So how do we diagnose BPH? There's a lot of ways to do it, and I'm sure your urologist has gone over many of these methods already. One is a digital rectal exam, not a fun exam, but it does examine the prostate size and check for nodules or irregularities. Another one is a bladder scan. With a bladder scan, we will measure how much urine is left in your bladder after you urinate. We have a scoring scale. It's called the International Prostate Symptom Scale, or IPSS. It's a range of 7 questions from 0 to 5 and goes over different types of urination, how you void, how irritating it is, and it actually gives us a good idea of where your baseline prostate score is. We will check PSA. That's important. So patients with enlarged prostates, their PSA level will increase. And that's why it's important to have a urologist on board to follow the PSA levels to make sure we're not missing anything that is cancerous. We can also check the urine for urinary tract infections, which can be a cause of an enlarged prostate. So how we test bladder function. So there's different ways to tell how your bladder's functioning. So remember, the prostate gland sits right below the bladder. When the prostate gland enlarges, it can cause obstruction to your urine flow. And over time, after years and years of obstructing that flow, the bladder, which is a muscle, gets tired and it doesn't squeeze as well. So we want to make sure your bladder is still functioning well. And the way to do that is to do something called a pressure flow study or a uric flow study. And we're going to watch a video on that right now.
Performing the test is simple. Instead of using a catheter, bladder pressure can be accurately quantified by identifying the pressure necessary to stop urine flow via the urocuff. Additionally, surface EMG electrodes can be placed on the abdomen and the perineum to quantify abdominal straining and dysenergic activity. The patient is then asked to urinate through the urocuff into the flow meter. Throughout urination, the urocuff simultaneously applies pressure to the urine stream while evaluating resulting changes in the flow rate. The pressure required to interrupt flow equates to the bladder pressure.
Some of you may have already had this study done, and again, it gives us a good idea to tell how well the bladder's actually functioning. There's also other type of tests called urodynamics, which just give us more detailed information about the bladder, how it's functioning, and how the urine is actually flowing. There's other types of advanced testing. One is cystoscopy, and this is where your urologist will stick a very small camera through the urethra into the bladder itself. They will be able to see the prostate, if it's blocking the urethra, if it's causing any pushing on the bladder, and to what extent the prostate's actually enlarged. Additionally, cystoscopy, again, which is a camera, can look for stones and tumors in the prostate gland and look for any irregularity in the bladder itself. Transrectal ultrasounds is an ultrasound where, as it sounds, it's placed through the rectum. And even though it's through the rectum, you can see the prostate very well. And you can determine the size and shape of the prostate. So these tests are all very important, again, to determine how big the prostate is, if it's had any effect on the bladder, and to what extent the effect is. So there's a lot of treatments for BPH, which is wonderful. There's lifestyle changes. There's certain medications we can avoid. There's certain medications we can actually take. And there's a whole variety of procedures that can help shrink down the prostate to get you back to a normal quality of life. So lifestyle changes. There are training such as bladder training or double voiding, which is sort of a technique to help you avoid going so frequently and almost training your bladder, which again, it's a muscle, to know when to go and help with the frequency and the urgency. I'm sure most of you on this call already have already limited your water intake before bed or limited your coffee and tea throughout the day. Unfortunately, we all love coffee. We all love tea. But having those are diuretics, they make you go to the bathroom more. So those lifestyle changes can be helpful, but it also can affect the quality of your life. So certain medications can make you urinate more, very similar to lifestyle changes. We can avoid certain medications if possible. Constipation can actually push on the bladder, making you go to the bathroom more frequently as well. And some medications are holistic. Some work better than others, but you got to be very careful when you're reading medications that are over the counter if they're actually going to be helpful or not. So medications, which most of you are probably familiar with, there's two groups. One is an alpha blocker, more familiarly would be Flomax or tamsulosin. A lot of patients are started on this. This does not actually shrink the prostate, but actually causes a relaxation and will improve urine flow. Again, these are the first steps you can take to improve the symptoms associated with an enlarged prostate gland. There's a whole nother group of medications, which are called 5-alpha reductase inhibitors. It's a long, fancy name, but the whole goal is, again, to improve your urine flow. This can actually reduce the prostate size over 3 to 12 months. And Proscar is one of the very common names that you may have heard or may be on, and also Avodart. So typically Flomax and Proscar or Flomax and Avodart are started. Some patients have a great response initially, which is wonderful. And then over months and years, their response to these medications isn't as good. And we're seeking another treatment option. So more on the procedure level. So we talked about lifestyle modifications. We talked about medications themselves, but actually procedures. So TURP, most you're probably already aware of, and these are all urological procedures. So they're through the penis procedures. So transurethral resection of the prostate, or TURP. So they go in, urology will go in through the penis and actually scrape the prostate and increase the urine flow. Aquablation is a different technique, but also through the penis. It uses water jets to remove excess tissue. Resume therapy is done in the office, and it's water vapor, which again, the goal is to go and actually shrink the prostate down and improve the obstruction. And Urolift, which uses sort of a retention suture to pull back the side of the prostate, almost like a curtain string. So again, these are all transurethral procedures, meaning they go through the penis. They're a little more invasive. And the whole goal, again, is to shrink or remove the prostate tissue to improve urination. So now we're going to get more into the procedure that I actually perform as an interventional radiologist. This is called prostate artery embolization. So the whole purpose of prostate artery embolization is to decrease the blood flow to the prostate. We are not killing the prostate gland. It is not dying inside your body. It's actually, we inject these very tiny little beads, and they go into the bloodstream and shrink the prostate down. So the procedure is performed either through the wrist or through the upper thigh. We prefer the wrist because it's easier recovery time for patients. No incision, no stitches, very tiny little pinhole in the skin. Once we get into the blood vessel, we use state-of-the-art X-ray equipment to navigate our devices, our catheters, which are very tiny little specially designed straws per se, through the bloodstream into the prostate arteries. And once we get into the prostate artery, we inject these very tiny beads, which you can see on your screen, into the prostate artery, and they go into the prostate gland, and they will shrink the prostate over time. So following this procedure, the prostate will start shrinking. Typically, symptoms become a little worse before they get better as the prostate is responding to treatment. But within the first about 2 to 3 weeks, patients will start to see improvement. Most patients see improvement at about the 4 to 6 week time point, and you will continually see improvement up to about 3 months. So what to expect in the office. So this is all done in an outpatient center. It takes about 90 minutes. So you'll come in an hour before the procedure. Procedure's about 90 minutes, and it'll be about an hour recovery time. So overall, you're in the center for about 3 to 4 hours, just to pre-op and post-op as well. It's not painful. So we use local lidocaine, and we also give twilight sleep or IV sedation, very similar to a colonoscopy sort of sedation, so you won't feel any pain. And again, after, you'll be in the recovery area for about an hour, where we take the bandage off. We send you home again with a very small little dressing, and we give you medications to help control any side effects. So again, we kind of talked about this already, but symptoms should improve for most patients. Some will see result in 2 to 3 weeks. Most patients will see improvement in about 4 to 6 weeks, and it will improve for up to 3 months after that. Again, it gets a little worse before it gets better, so you can expect a low-grade fever, some pelvic pain and pressure. The urinary frequency is probably going to get a little worse for the first 5 to 7 days. And again, we'll send you home with medications to help control all that. There's really not any true bed rest time with this procedure. You're not admitted overnight. For most patients, we do not have to put in a Foley catheter for the procedure for most patients. And then, the next day, I'll launch you up walking, moving around, back to your day-to-day activities. Majority of patients will use the wrist for access to get into the bloodstream. So no heavy lifting for about 5 to 7 days. But besides that, again, in 24 hours, I want you up walking, moving around, back to day-to-day activities. So it's very successful. So it's 85 to 90% successful. So out of 100 patients, 10 to 15 may not get the results they want or get partial results. If that is the case, this does not mean you can't get additional procedures. So getting this done does not mean you can still get any of it through the penis procedures, the TURPs, the Resume, the Urolifts. And usually the symptoms typically stay improved for about 5 to 7 years, which is the recent literature. At that time point, symptoms typically don't come on as strong. So most patients kind of let it ride and they're like, I don't need anything else. If we do need to retreat, we can definitely retreat this same method with a PAE, or again, all the urology transurethral procedures are still on the table. We sort of went over this already, so there's really no heavy lifting for about a week, but other than that, no true bed rest time, no stitches to get removed, tiny incision, tiny little pinhole through the skin. So the beads themselves are a polymer gelatin. A question I get a lot is, do these beads dissolve? They do not dissolve. They stay in the body forever. They lodge in the prostate gland and they decrease the blood flow, so the prostate will shrink down. They are totally inert. They do not emit radiation. They are not metallic. They will not set off any alarms. They will not, they're okay in an MRI unit because they're not metallic, so no issues there. We've been using these beads for decades. So the beads do not travel. So I do get a lot of questions as well regarding non-target embolization. So at the time of injection, so we have state-of-the-art X-ray equipment. Essentially, it's a $1 million machine that has very specialized navigational hardware to get us into the prostate arteries. Once we get in the prostate arteries, we will inject these little beads under X-ray. So we will see where the beads are going when we inject. If you think of the prostate arteries almost as a tree trunk, there are other blood vessels there as well. Inadvertently, some beads are so tiny can go into other blood vessels in the surrounding organs. That's called non-target embolization. This is rare. This is only reported to occur in about 2 to 6% of procedures, and having actual complications and side effects from this is less than 1%. So the complications of these tiny beads going other places is extremely rare, and even rarer are actual major complications. So here's again is a list of all the BPH treatments. At the top is prostate artery embolization. Again, a lot of patients like this procedure because it's minimally invasive. There's no incisions. You're not admitted to a hospital overnight. The risks are extremely low. This can be used again down the road if it has to be. Again, there's no, so size-wise, there's no upper limit of size, and it's very effective. So again, this is just going over PAE again. So this image shows a comparison of after treatment, how much the prostate gland will shrink. So the prostate gland can shrink up to 40% after the procedure, and it will shrink continually for several months after. Typically, you have the max shrinkage effect at about 3 months post-procedure. And again, it's performed in an outpatient setting with twilight sleep. There's no incisions. It's essentially painless. We use moderate sedation or twilight sleep for the procedure. Complication rate is extremely low. Usually we'll see improvement in about 2 to 3 weeks and return to full activity in about a week. And regarding prostate size and shrinkage, so we're not as concerned by how much the prostate gland actually shrinks, but more how your symptoms have improved. So some patients, they don't get as much shrinkage of the gland, but their symptoms are significantly improved, and that's a win for us. We don't care as much of how much it's actually shrunk down. So over here, sort of a list of who are actually candidates for this procedure itself. I'm sure this will answer a lot of questions. So for gland size, this is one of the most important metrics we use for candidacy for the procedure. So prostate gland should be greater than 40 grams. Anything less than 40 grams, essentially the prostate is small. So on the range of big prostates, that's a pretty small prostate, less than 40 grams. So there's not as much tissue to actually shrink. So again, the purpose of the procedure is to shrink the prostate down. And a prostate gland that small, there's not much tissue to shrink, so there won't be much improvements. And at that point, we'll have a conversation with your urologist and go over other treatment options. There's really no upper limit of size. So we've treated patients with prostate sizes up to and greater than 200 grams. Patients who have hematuria or experience a lot of bleeding in their urine, a lot of blood in their urine. It's very effective for actually stopping bleeding in the urine as the blood vessels are blocked. The bleeding usually stops pretty quickly. A lot of patients who are on medication, you're either on Flomax or Proscar or Avidzar, and there's a lot of unwanted side effects from these medications. Another goal would be to get you off the medications. So in that case, we would do the procedure. We would wait 3 months, have you go back to see your urologist 3 months after the procedure, and then your urologist would start to wean you off these medications. Either because there's side effects of these complications that you don't want to be on them anymore, or they're not as effective as they used to be. One of the main points of this procedure that a lot of patients like is that there's really no negative effect on sexual function. So some of the transurethral or through the penis procedures have a negative effect on sexual function, and this does not. There's no reported negative effect on sexual function. If you already have erectile dysfunction, this will not make it any better, but it won't make it any worse. Other patients who are non-surgical candidates, again, you do not need general anesthesia for this procedure. We do it on patients who are on blood thinners, so we do not stop blood thinners for this procedure as well. So patients who can stay on blood thinners, who do not have to go through general anesthesia, again, it's a great minimally invasive option for. If you have prostate cancer, you can still have this procedure. More importantly is to treat the prostate cancer first. We treat a lot of patients who have had prostate cancer and they're on surveillance or they've completed treatment. And then but they still have these BPH symptoms, and they're definitely candidates for the procedure. Any patients who have failed any of the procedures we mentioned, such as TURP, Resume, Urolift, and the bladder still functions relatively well, we will still, obviously, you're definitely going to be a candidate for this procedure as well. So this is a picture from our actual IR center in Chesterbrook. You can see this a very large screen, the monitor there, which is optimized with very high resolution to see these prostate arteries. These prostate arteries are about 3 millimeters, so about 7 to 8 pieces of hair. That's how big they are. And again, this machine is optimized with high resolution and with navigational capabilities to help us locate these vessels and treat them appropriately. If you're interested, absolutely reach out to your urologist and have them send you over for a consult. So there would be 3 encounters at the center. One would be the consult, then would be the procedure, and then we do a follow-up at the center 4 to 6 weeks after. And then you would see your urologist 3 months after that. So here's a number at the center. Again, if you're interested in the procedure, we would love to see you in consult. Reach out to your urologist, and they will send over a consult. We'll get you in as soon as we can. I'm now going to go over to the question list and go over as many questions as I can. I will repeat the questions first, just so everyone can hear, and then we'll go through as many Q&A questions as we can during this time. So first question. I had a urolift almost 3 years ago, and I'm starting to have symptoms again. This is, unfortunately, a lot of patients we see. They've had either a urolift. Some patients have had 2 or 3 urolifts, or another transurethral procedure, such as Resume or aquablation. And absolutely, if symptoms have come back, we treat a lot of patients who've had them. We'll see you as a consult, and this can help shrink the prostate glands. Just because you had a urolift does not mean you cannot have this procedure. Next question. Does this procedure reduce prostate size? Yes, this procedure should shrink the prostate gland about 20 to 40% of its size. Again, we're not as concerned with how much it shrinks, but it's symptom improvement. Next question. What is the prognosis when PAE is only done on one side, when the other side arteries are too small or tortuous to embolize? Are there studies? So it's another great question. This is questions about prostate anatomy. So in my experience, and again, this procedure's been around for at least 15 years. I've embolized hundreds of patients. The reason that as meaning you patients, have now aware of this procedure is because it was introduced into the AUA, the Urologic Association's workflow or protocol for treatment of BPH in 2023. So it's been around for at least 15 years. I've been performing embolizations for 10 years. So the procedure's not new at all. Again, it's just sort of new to urology patients because now it's been introduced into the workflow. So back to that anatomy question. So everyone's created different, and even within the same patient, anatomy is different. So there's typically two blood vessels that supply the prostate gland. The prostate gland looks like a walnut. There's a left lobe and a right lobe. So there's a left prostatic artery and a right prostatic artery. Sometimes we can knock it into both sides. Sometimes the one side is very narrow, or it's very windy or tortuous, and we cannot get our devices there, and we can only treat one side. And that's happened for a good amount of patients, and they have great results. So as long as we can get a good amount of beads into the prostate gland, it is very reasonable, and it really doesn't affect results if we can only treat one side. Great question. Next question. I'm on finasteride. Will I be able to stop it after PAE? So that is a goal. So one of the main goals of the procedure is if you're on, again, any of the medications, Flomax, Avodart, Proscar, and either they're not working anymore, or they're less effective than they used to be, or they're having unwanted side effects such as dizziness, causing erectile dysfunction, then that is the goal. The goal would be to stop the medications. We would have you follow up with your urologist 3 months after the procedure, and they would start weaning you off of the medications with the goal to keep you off of them forever if we can. Next question. Do these beads stay in the body forever, or does the body absorb them? So the beads stay in your body forever. Once they're in place, they do not go anywhere. The only potential risk, which again is very, very, very low, is at the time that we inject them, which is under X-ray visualization, that they can go into other surrounding blood vessels. That's called non-target embolization. That occurs within 2 to 6% of cases. And any serious complications of that is much less than 1%. But they do stay in your body forever. They do not dissolve, and they'll stay in your prostate gland. So next question regarding renal function. So can the procedure be done without contrast? So unfortunately, no. We have to inject intravenous contrast to actually see the blood vessels. For patients with chronic kidney disease, we try to limit contrast as much as possible. Sometimes we will talk to your nephrologist and determine a baseline renal function. And we have done a lot of patients with chronic kidney disease and limit contrast to, again, as little as possible, and they do wonderful. Next question. After PAE, can I drive home? Unfortunately not, and that's because of the sedation. So you really can't operate any motorized vehicle or heavy machinery for 24 hours after the procedure. So you will need a ride to the procedure and coming back home from the procedure. So some of these are redundant questions, so I'm sort of skipping through some of them. Next question, how do you determine prostate size in grams? Another good question. So prostate size can be calculated using a bunch of different modalities. So transrectal ultrasound with an ultrasound probe through the rectum can show the prostate gland very well. And there's certain volume calculations you can use to calculate the volume. I can also calculate the volume off an MRI of the pelvis. Or if you had any CAT scan done of your abdomen or pelvis, I can measure it in 3 dimensions and put it through a volume calculator and determine how big the prostate actually is. Next question. If someone is using a catheter to urinate, would this make that unnecessary? So that is a goal. We have a lot of patients that come in who are either straight cathing, so they're putting a catheter in themselves several times a day, or they have an indwelling catheter and they're living with it 24/7. So the goal is, if we can, shrink the prostate down, improve the flow, and stop use of the catheter. That's a goal we always shoot for. Some patients who have a Foley or an indwelling catheter for years, it's difficult because, again, the bladder has to still be functional. So the bladder's a muscle, and if that stops squeezing and gets, per se, like a floppy bag and there's no strength behind it, even if we shrink the prostate, the results aren't that great. So with these specific patients, we would work with your urologist to find out the best solution. But yes, we do treat patients all the time, and the goal would be to remove the Foley catheter or stop straight cathing. Will the prostate artery embolization procedure reduce the size of a benign cyst on the prostate? Typically, since a cyst is not really tissue, it's just sort of a fluid-filled sac, we don't get much shrinkage of an actual cyst, but typically that cyst would not be what's causing the problem anyway. Just a reduction of the actual prostate gland should improve symptoms. How long does the procedure take? So procedure is about 90 minutes start to finish, but again, you'll be at the center for about 3.5 hours. You have to get there an hour before, just do all the pre-op paperwork and meet our team. Procedure's 90 minutes, then you'll stay for about an hour after. So give or take about 3 hours or so. Final question, does the procedure have a negative effect on ejaculation like Flomax does? So again, one of the major benefits about this procedure is it does not affect erectile function. So no reported studies have shown that this causes erectile dysfunction by any means. So I think that's all the questions I have right now. Again, if you're interested, I'd love to see you in consult at the center. We're at Chesterbrook. It's about 10 minutes from the King of Prussia Mall. Have your urologist send over a consult, and we'll go from there. Thanks again, guys. Thank you.